Okay, so this one is advanced care planning. And the main code we're going to be using here is the two codes we're going to be using are the 99497, which is advanced care planning the first 30 minutes, and then 99498, which is advanced care planning additional 30 minutes. So essentially, advanced care planning codes are used to report face to face service between a physician or qualified health professional and a patient, family member, or surrogate in counseling and discussing advanced directives. This can happen with or without completing relevant legal forms. So this can just be a discussion as to what your goals of care are. DNR, DNI discussions are included in this. Sometimes you may have long conversations with the family with palliative care involved where you will burn through the time requirement for this. So it's important that you're billing for this separately from what you're doing with E&M because you're dedicating time to advanced care planning, which is very important to CMS. And again, this can be just recording the wishes of the patient, having to change orders in regard to full code to DNR, DNI, and what the future looks like. So the 99497 is the first 30 minutes of face-to-face communication with the patient, family members, and or surrogate or caregivers with a minimum of 16 minutes. 16 minutes is really not that much time when you sit down and you start discussing goals of care and advanced directives and paperwork that's required and DNR, DNI, you can burn through 16 minutes very, very quickly, especially if patients have questions about what's DNR versus DNI and what does that mean. So it's very easy to build this 99497, just getting a minimum of 60 minutes, but it is from 16 minutes to 30 minutes. So in order to then use the 99498, which is an additional 30 minutes, you first have to use all the 30 minutes discussing advanced care planning with this patient for 30 minutes. And then if you go over by an additional 16 minutes, you can then build a 99498 as a modifier on top of the 99497, saying that you spent more than 30 minutes discussing this whole thing with the family, caregivers, or whoever is at bedside. This is not limited to talking about healthcare proxy if they're going to go into surgery, and if it's a high risk surgery, questioning them about who's going to be making decisions when you're under if something were to happen, durable power of attorney for healthcare, having a living will or an advanced directive, and then medical orders for life sustaining treatment. All of this is included in this discussion. It will be in this case reported separately when performed on the same day of service as the E&M. So typically if you end up billing, let's say a 99233 progress note, and then you have this further discussion with the family about advanced care planning and what their wishes are, you would then build this on top of the 99233. Again, discussion of advanced directives with the patient, the family. I mean, and you can talk to the family on the phone, but it's almost as if you have the discussion with the patient in the room. And if someone is on speakerphone who's also part of the discussion, that counts because that's still time that you've dedicated to discussing what the patient, how the patient wants to navigate the healthcare system in regard to DNR, DNI, and what they want medicine to do for them and what they don't want medicine to do for them depending on their situation. So this doesn't include active management of any of the patient's problems. This is separate from the E&M. This is sitting down saying what is it exactly do you want to get out of the stay here, and how aggressive would you like us to get with your care? So the minimum documentation that's required here, and I do apologize, I don't have a dot phrase for this one, and the reason is because it can be so different from patient to patient. But what is important is that you include the content of what you guys discussed. So it's important that you're not forcing this discussion with the family. You want them to inquire as to what is an advanced directive and who's making decisions. But it's important for you to detail in the note, and this can be really short, especially with Dragon Dictation. You can quickly say, well, I explained what these things are to them and the patient understands who was involved in the discussion. And you can, in that assessment plan, when you do, let's say you have severe protein calorie malnutrition or you're going in a palliative care route, um, in that part of your assessment plan, whether it's problem based or systems based, you can put the time spent in face to face. And I know I went over the time a little bit, but I'll give you some examples just so you know how to use the time, and how to add up the time. So the time statement. So again, think about it as being a minimum of 16 minutes. So if you spend a minimum of 16 minutes with that patient discussing advanced care planning, then you do qualify to bill that 99497. So this doesn't have to be long, but you should put what required the advanced care planning time. So again, you don't want to get too generic, but if the patient has multiple comorbidities and you had this discussion, then it should be very easy for you to convince CMS that this discussion was needed. You're not going to be able to convince them that you had a long advanced care planning discussion with a 26-year-old who came in with cyclic vomiting syndrome. So that's not going to work. It has to make sense why you would discuss DNR code status or advanced directives with this patient. So here's an example. If you spend 44 minutes going over advanced care planning, you would only bill a 99497. And why is that? Because I had mentioned that if you spent 16 minutes with the patient, you would qualify. So in this case, it's from 16 to 30 minutes. So if you spent the full 30 minutes, you would then bill the 99497. But you can't bill a 99498, which is an additional 30 minutes because you have to spend at least a minimum of 16 minutes to then add that next modifier. In this case, you spent 30 minutes with the patient and then only 14 extra minutes on top of that 30-minute mark, which is why you can only bill the 99497. If you put 46 minutes in there, now you spent the total 30 plus an additional 16, which is the minimum for that 99498. And sorry, this is getting confusing in my head, but essentially because you spent 46 minutes, you can now bill the 99497, which is the first 30 minutes, plus the 99498, which is a minimum of additional 16 minutes in addition to the 30 minutes that was documented with the original 99497. And then the note supports the total time, which is 76 minutes for advanced care planning. So, excuse me, another example, if you spent 76 minutes, so you could do this in your head. You spent full 30 minutes, which means you qualify for the 99497, done. You then spent in another 30 minutes with the patient, which qualifies for the 99498. And so that's 60 minutes. And you spent 16 minutes again with that patient on top. So 76 minutes you spent, which means you could bill the 99497 and then you could bill the 99498 times 2 because you spent a total of 76 minutes discussing advanced care planning. I don't see a scenario in which you would spend that much time discussing it, but sometimes these meetings can get out of hand and they can go on for a long time and multiple family members can get involved. So it's important that if it does run over, you are accurately documenting and billing for your time, because your time is very valuable. And these are the references from where a lot of these CPT codes came from. And then I had mentioned Gina Evans in one of my other videos, but she is a trainer for the ICD-10 codes and also an educator within the Emory system. And she's been wonderful. She typically has these lectures that she gives to almost every hospital twice a year. So if you get a chance, please sign up for her next slide deck presentation because they are amazing. And this slide deck actually came from her. Okay, thanks. Bye.